Hello everyone, this is Dr. MOUNIKA, a critical care pharmacotherapist. Today, I'll explain an important topic in ICU practice. It's a step-by-step approach for antibiotic stewardship in critically ill patients. Antibiotics save lives, but inappropriate use leads to antimicrobial resistance, treatment failure, and increased mortality. So, every ICU must follow a structured antibiotic strategy. Let's understand this in a 10 simple clinical practice. Our first step is that plan antibiotic selection. In ICU, antibiotics are usually used in 3 situations. One is for prophylactic treatment, mainly like perioperative. And next is the empirical therapy, when an infection is suspected but your culture is still pending. And the next one is that definitive therapy, when infection is confirmed by culture reports. When selecting antibiotics, we must consider this: clinical condition and severity of illness, likely infection source, possible pathogens, and recent antibiotic exposure, and local resistant patterns and hospital antibiogram. The reason for antibiotic selection should always be documented. In difficult cases, early consultation with an infectious disease specialist is highly recommended. And here, step 2. Send cultures before antibiotics. See, whenever infection is suspected, appropriate cultures should be sent before starting antibiotics. Common cultures includes blood cultures, urine cultures, sputum cultures. These should be collected properly and transported immediately to the microbiology laboratory to ensure accurate results. And here, step 3. Start antibiotics early in sepsis. In septic shock, timing is crucial. Studies show that every hour delay in starting antibiotic increases the mortality. Therefore, antibiotics should be started within 1 hour of recognizing septic shock. Remember a simple principle: time is an issue in sepsis management. And your step 4 is choose empirical antibiotics carefully. Empirical antibiotics should cover most likely pathogens until cultures are available. Selection should depend on patient's history, type of infection, type of bacteria, local bacterial resistant pattern, and previous colonization of infection history. Also, avoid repeating the same antibiotic class recently used by the patient, because as resistance may develop soon. In some clinical scenarios, we must also consider viral, fungal, or parasitic infections too. And your step 5 is assess the risk of drug-resistant organisms. Critically ill patients may develop infections caused by multi-drug resistant organisms. So, important risk factors includes advanced age, comorbid conditions, diabetes, renal disease, or any other chronic health issues, and a usage of immunosuppressants, prolonged hospital stay, or indwelling device such as urinary catheters or central lines. If these risk factors are present, broader antibiotic coverage may be required initially. And your step 6 is follow pharmacokinetics and pharmacodynamic parameters. Correct dose administration and methods are very important in ICU. Correct dose and administration methods are very important in ICU sector. 2 key concepts are time-dependent antibiotics, example like beta-lactamase. Their effectiveness depends on how long drug levels remain above the minimum inhibitory concentration. So these drugs are often given as extended or continuous infusion. The other one is that concentration dependent antibiotics. Example like aminoglycosides. Their effect depends on high peak concentration. They are given as once daily high dose therapy. Also remember to adjust antibiotic dose in renal and hepatic dysfunction patients. And your seventh step is that daily assessment and de-escalation. Patients should be assessed daily. Once culture results are available, narrow the antibiotic spectrum. Stop unnecessary antibiotics. Continue targeted therapy. Clinical improvement can be assessed using decreased in your leukocyte count, falling in CRP levels, low procalcitonin levels. De-escalation helps reduce resistance and toxicity too. And your step 8 is that use combination therapy in selected cases. Combination antibiotic therapy is recommended in certain situations, like multi-drug resistant organisms like Acetobacter or Pseudomonas, or neutropenic sepsis, severe infections with shock or respiratory failure. Example like your beta-lactam plus macrolide therapy for severe pneumococcal infection. However, some combinations should be avoided due to toxicity. For example, vancomycin with piperacillin tazobactam can increase the risk of kidney injury. And the step 9 is that decide appropriate duration. Antibiotic duration should be individualized. For most infection, 4 to 7 days of therapy is usually sufficient if the patient improves. Longer duration may be required in slow clinical response, unbrainable infection source, immunocompromised patients, or if culture results are negative and the patient improves. Antibiotics can be often stopped within 5 days. And your step 10 is implement an antibiotic stewardship program. Every hospital should establish an antibiotic stewardship program. The team usually includes infectious disease specialist, microbiologist, clinical pharmacist, infection control nurse, ICU physicians. The goals are rational antibiotic use, monitoring resistance pattern, utilizing hospital antibiograms, promoting evidence-based prescription. Proper stewardship improves patient outcomes and reduces antimicrobial resistance. Overall, I would like to tell you is that antibiotic use in ICU requires early diagnosis, correct empirical therapy, pharmacokinetics and dynamic optimization, culture-guided de-escalation, and strong stewardship programs. As healthcare professionals, it is our responsibility to protect the antibiotics for the future generations too. Thank you so much for watching.